Hello, I'm Dr. Richard Senelick. I'm a neurologist who specializes in neurorehabilitation, and I'm the editor-in-chief of Encompass Health Press. I'm glad you're able to join us for this educational presentation on short and long-term consequences of critical illness, and I hope I'm going to be able to show you why this is such an important diagnosis for rehabilitation professionals. This presentation is one of several that we have available to healthcare professionals and particularly physicians for continuing medical education credit, and I hope you will contact us and look online for our other presentations. I have a personal interest in this topic and hope to explain to you how I became interested in this and why it became such an important diagnosis for rehabilitation professionals. First, why are we talking about this? Part of it is because there are so many of these cases that go unrecognized as a rehabilitation diagnosis, and these patients don't get sent for inpatient rehabilitation or comprehensive rehabilitation. There's over 750,000 cases of severe sepsis each year, which is approximately the same as stroke. I think stroke is 795,000 right now. As far as if we count new and recurrent strokes. So it's a large number of patients. We all recognize that stroke patients need aggressive rehabilitation, but frequently these patients are overlooked and they're labeled as being deconditioned or debilitated and go to a skilled nursing facility, go home without the appropriate care. They represent 10% of all ICU admissions, and I'm going to show you why this is really important, because if we look at the cognitive, behavioral, and physical consequences of being in the ICU for 5, 7, and more days, it's significant. So there's an even larger population of patients, close to 8 million patients, that again get labeled as being deconditioned or debilitated, get sent home, sent to a skilled nursing facility, and are not thought to be rehabilitation candidates. So hopefully at the end of this hour, I will have raised your level of awareness. Before the type of intensive care units that we have today, there was an 80% mortality for septic shock. It's now down to about 20 to 30%, but that's still significant. If you start to think of other diseases and conditions, there aren't that many that have a 20 to 30% mortality. Many of physicians that I talk to say that a weekend that they're on call doesn't go by, particularly the urologists, when they aren't seeing somebody in the ICU that is in septic shock from urosepsis. The intensivists have become much more aware of this. Many hospitals now have a code sepsis. We're all familiar with code blues for an arrest. And now there's a code sepsis, although we'll talk about the approach to this and that sort of initial 6 hours, and unfortunately that this aggressive approach to it hasn't changed significantly the mortality. But even with the mortality, that means there's 500,000 people that have physical, cognitive, and behavioral impairments that need rehabilitation. So let's go back and give a little history and put a little flavor and color to this. Hippocrates, the great father of medicine, claimed that the process sepsis was that by which flesh rots and swamps generate foul airs and wounds fester. So he knew it was something. He wasn't sure what was causing it, but that he recognized that patients became septic. Galen considered sepsis necessary for wound healing, so that a certain amount of patients who, I guess if they were healthy enough to survive being septic, their wounds healed and they survived, and that those that didn't, he thought, well, I guess they weren't sick enough. Clearly we know now that that's not the case. And the modern germ area starts with Louis Pasteur, who recognized systemic infections, or what was called blood poisoning. But the problem is the germ theory, the idea that we have these germs or bacteria, E. coli and urosepsis, or strep, pneumonia, leading to septic shock. didn't explain why these patients do so poorly and why they have so many multi-organ problems. You give the antibiotics, you aggressively treat them, you aggressively interact in that first couple hours, and you think you have the infection under control. And despite that, the patient continues to deteriorate and has a host of problems that we're going to talk about. And the problem is that the patient or the host has a systemic inflammatory response, or what's called SIRS. This complicated drawing comes out of an article in the New England Journal of Medicine, and the New England Journal, which is, I think everyone agrees, the premier journal in medicine, did a series of articles. I'm trying to remember if it was 2016, 2017, or 2015, 2016. Today, as I'm doing this lecture, we're at the end of April 2018 to give you a reference time. So if new things have come out that contradict what I say. But they recognized what a big problem septic shock was and came out with this series of articles. If we look at, let me see if I can get my pointer to work here. Here we go. So up in the left-hand corner are the pathogen factors. So this one might be the urosepsis, the pyelonephrosis, bad strep pneumonia, and you have a load of the bacteria, the virulence, and this is attacking the body. And we think, well, okay, we're going to give strong, powerful antibiotics, and it's sensitive to that, and the patient should respond. But the problem is that we now get this interaction. So we get a pro-inflammatory response, and what happens is the cytokines or pro-inflammatory chemicals are released throughout the body, and they just light up every organ. And then we get complement, so an autoimmune response, some coagulation that we're going to talk about in the next slide, and that can lead to cell death. So that this cytokines can light up the muscles, the nerves, the brain, the lining of the heart to give us pericarditis, the lungs, and now we start to leak fluid out of all the blood vessels, and we'll talk about that some more as we talk about all the complications. The host or the body responds, and we call this how the body responds in combination with the environment or epigenetics. So how are you genetically predisposed to respond? The elderly don't do as well as the young, although I have seen quite a few young patients who have died, quite a few young patients who have had terrible complications and limb loss as a result of this, and older patients that have really done quite well. So as a rule, youth helps, but not always. So we see that the body now comes up with an anti-inflammatory response to these cytokines, trying to shut down the cytokines. And this complex autoimmune system that's being mobilized is taking place within the body. And we'll talk in just a minute about how we've tried to address these. At the same time, we have this complicated vascular response. So we have an increase in coagulation and a decrease in anticoagulation, DIC, or disseminated intravascular coagulopathy. The platelet count drops, and we give platelet transfusions. We worry about patients bleeding. They can bleed into their brain. But also at the same time with that is an increase in thrombosis. Where is my pointer? I think I've lost it. There we go. So that we can get blood clots, and as I show you in the brain, some MRI scans and some sections of the brain, we can get small strokes. We worry about bleeding in the brain, but we also worry about thrombosis and eventually other organs having problems with oxygenation and tissue damage. This is a whole series of articles and studies. I guess it was even earlier. These came out in 2014. Where they were trying to come up with, if we really get aggressive that first 6 hours and we have a protocol for how to approach this, does it make a difference in outcome of the patients? And unfortunately, it didn't. There were some experimental drugs, Zygris, which people thought would have work against the inflammatory reaction, which turned out to be very expensive and not have a positive outcome. Other experimental studies using lactoferrin, mother's milk, also turned out to not be very successful. This was another study, came out in 2015 with the same thing. So that basically our approach to this is really good ICU care and the things we're going to talk about in just, I think, probably the next slide. But so far we haven't come up with a good medication that can shut down this cascade of problems, this cytokine response, this pro-inflammatory response that's causing so many problems. Where this got personal for me, in the picture on the right, is not my wife, but it's pretty much what things looked like. So many, many years ago, I married a forest ranger's daughter, and we have a cabin summer home in the forests of Idaho, about 25 miles from West Yellowstone. And she spends pretty much the whole summer, and I'll go back and forth. And I got up there, it'll be 6 years ago this September, and she woke up one morning and she said, "I've never felt this bad in my life." And I looked at her, and indeed, she looked terrible. Now, because we're in the middle of the forest, I keep everything you can imagine, and I took out my doctor bag, and her blood pressure was 60 over nothing. And I realized we were really in trouble, and packed up a few things in a Suburban and put her in the back seat and started to head down off the mountain toward Idaho Falls, an hour and a half away. And I thought we were in good shape when we got to the emergency room, but she was already clearly septic, and from urosepsis, from an asymptomatic kidney stone, which surprisingly asymptomatic. And by 9 o'clock that night, this is pretty much what she looked like. She was on a ventilator, on pressors, fluids. The little green machine we'll talk about in a minute showed up a couple days later, and that's continuous renal dialysis. And we were in trouble, and it's amazing how fast things happen. So that everything starts to leak. You get this cytokine release, and all of the blood vessels in the body start to leak fluid, and you get third spacing, and can gain over 40 pounds of fluid in 24 hours. And the problem is trying to maintain mean arterial pressure in the brain so that you can perfuse the brain and not end up with significant brain damage and keep the heart going. So the lungs now have shock lung or adult respiratory distress syndrome, and you get this whiteout on a chest x-ray. The blood pressure is really hard to maintain, and you're giving Levophed and pressors, epinephrine, to try and keep it going. That works much better. Don't like to give dopamine. And at the same time, you're pouring in all this fluid, and it just keeps going out into third spaces, into extremities, into the abdomen. And you're desperately trying to keep the brain intact at the expense of the limbs. So it's not uncommon to see the hands and the feet as dusky and purple, and even getting frank gangrene, which we were fortunate didn't happen, but I'm going to show you an example of that. And you have no choice. So it's at the expense of peripheral organs, and those become rehabilitation issues. Develop renal failure, and that's this little green machine. One of the problems, you can't do regular renal dialysis because the patient's so fragile, and you're desperately trying to maintain blood pressure, that if you just turn the patient over on their side, their pressure may drop out. But particularly if you tried to dialyze them with a normal dialysis machine, you'd be exchanging too much fluid at any given time, and the pressure again would drop out. So this wonderful little machine dialyzes like 75 cc's an hour, and it's continuous, and slowly dialyzes the patient and takes care of the renal failure, which usually, if the patient survives, is reversible. And we're going to then spend more time on encephalopathy. Patients may be delirious before they have to be paralyzed and then put on a propofol drip in order to adequately ventilate them. And delirium itself carries a poor prognosis, but also now we've put the patient in a coma, basically, in order to ventilate them and manage all of these things. And so we really don't know what's going on until, if they survive, they come out the other end, and we'll talk about, well, how do you evaluate this so that while they're in this state, in this picture that we see on the right, we really don't know what's going on in the head. And we're going to talk about critical illness, myopathies, and neuropathies. So we'll do that first. And some of the synonyms for this that have been around for a long time are ICU neuropathy, myopathy of critical illness, quadriplegic myopathy, necrotizing myopathy. And the accepted term today is really critical illness, either polyneuropathy and myopathy or polyneuromyopathy. Either one of those is going to be the literature. So let's talk anatomy for a little bit, and simple anatomy. We just tend to think of muscles and nerves as not being particularly special when you think about the brain or even liver and kidneys, which are performing multiple metabolic functions. And we think, well, the muscle, what does it do? It's attached, and muscle contracts, and something extends or contracts. If it's the diaphragm and intercostal muscles, it allows us to breathe. But as I'm going to show you, and hopefully I think the next slide, it's a complicated metabolic process. So it's each one of these myofibrils that are inside the muscle here has a complicated metabolic machine inside it. So here we have a nerve with a myelin sheath that attaches at its motor point to the muscle, and within that are all the little individual muscle fibers. But really, it's a complicated metabolic machine. Go back to elementary biology, and here's your mitochondria, which is your little metabolic engine, which creates the energy for the muscle. And so we have all these mitochondria in there. Here is the nerve coming in, and lo and behold, here are those cytokines. So these pro-inflammatory cytokines are released and attack the nerve, attack the muscle fibers, and attack the mitochondria. So it tends to shut down the energy process that's taking place. It causes deterioration of the muscle, and the same thing within the nerve. And if we look at this lower part, this is the blood vessel coming in to supply the nerve, and these get attacked the same way by the cytokines and affect the microcirculation within the muscle fiber. So that we don't think too much about it because the patient's laying there on a ventilator and they're getting pressors, they're on dialysis, and we paralyzed them. And while all that's going on, the nerves and the muscles are being attacked by this metabolic process that we really don't have a way of measuring. And the thought process is, well, I'm trying to save this patient's life, so we'll just deal with that when this is all over. And there's nothing wrong with that thinking. The intensivists, critical care doctors, that's their job. But it's our job as rehabilitation specialists to then look for these problems and to deal with it after the fact. So what's happening is called SIRS, or a Systemic Inflammatory Response Syndrome. And it's the predisposing factor for critical illness myopathy, CIM, or critical illness polyneuropathy, CIP, and it's those pro-inflammatory factors that I showed you. And they may fight infection, but at the same time, they're causing muscle and nerve degradation and attack the microcirculation, increase permeability. You get all of this fluid leaking out. Not so much in septic shock. We've learned that using steroids probably has a negative effect, but it's used in other disorders where we use high-dose steroids and we're trying to treat inflammation. But we know that steroids can also cause a myopathy, and you can get a steroid myopathy. Now, there's two different types of muscle fibers. Type 1 are the slow twitch fibers, and the example we always use, well, that's the marathon runner. Those are the slow, sustained activity. And then there's type 2 fibers, which are the fast twitch fibers for short bursts of energies, with the idea that, well, a sprinter would need that. Well, there's a distribution of these type of fibers within the muscles in the body, depending on what that muscle needs to do. So this is a story that needs to get us to perk up our ears and pay attention and look for critical illness myopathy. Type 2 fibers are the type that are most affected by critical illness myopathy. They're more susceptible. And as it turns out, the diaphragm and the intercostal muscles are composed of about 40% of type 2 muscles. So breathing, when I take a deep breath, my diaphragm goes down, my intercostal muscles, some of them contract when I take a breath in and some contract when I exhale. And this is the patient where we get the story that, they responded well to antibiotics. The pressor agents did their job. We were able to wean them off their pressors. Renal function came back, discontinued dialysis, and they're making urine. That's all working well, but we just can't wean them from the ventilator. Or by the time we see them and evaluate them for rehabilitation, the story is, they were difficult to wean from the ventilator. It took a couple of weeks to wean them from the ventilator. And it turns out that these patients had a critical illness myopathy affecting their type 2 fibers and affecting the diaphragm and intercostal muscles. And it just ought to be a wake-up call to us that, if it affected the diaphragm and the intercostal muscles, it probably affected the other muscles. And I'm going to look and see, do they have proximal shoulder, let me get my tongue out of the way, and hip girdle weakness and have a critical illness myopathy elsewhere, and that's why they're weak. As we talk about, we just don't want to say patients are weak. We need to look for an explanation, and there usually is an explanation as to what underlying disease process is going on that's causing the weakness, rather than just say, well, the patient is weak and therefore was admitted for rehabilitation. We're looking for that underlying process. So how common is this? Here's an article from the Green Journal of Neurology all the way back in 2006. And the awareness of critical illness neuropathy myopathy was much more in the intensive literature, critical care medicine, neurology literature, than in the rehabilitation literature, and is now showing up more and more in the rehabilitation literature as there is an awareness of how it really impacts the rehabilitation process and that these patients really need rehabilitation. You can see from this study, and on the left side, that about 50% of the patients in this study had a critical illness, neuropathy, myopathy, and that most of the patients that had the problem had both. So that most of the time you don't have it in isolation. You don't have just a myopathy or just a neuropathy. You're going to have both. And at what point do you develop it? Let me see if I can get my pointer to work again. So this is at day 14. You can see most of the patients that were going to get it had it. And this is day 21, picked up that extra 5%. So that by the time we see a patient and we're evaluating them for inpatient rehabilitation, they've been in the intensive care unit. They've been sick and for 14 days. These patients are really sick. This is not the type of patient where we're seeing at the 4th, 5th, 6th day, where yes, we're seeing patients much earlier than we used to, and our patients are much sicker than they used to be. But most of the time, these folks have this problem by the time we're seeing them. The diagnosis may not have been made in the ICU because they've been paralyzed, they've been on a ventilator, people have been saving their lives, and we're not faulting anybody for not making the diagnosis there, but the responsibility now becomes that of the rehabilitation physician to appropriately make the diagnosis and to institute the appropriate rehabilitation process. As you can see, we're now seeing increasing number of articles showing up in the rehabilitation literature. There's a journal of PM&R just in 2017. That article's headline is published or online ahead of publication, and it's looking at what happens to these patients. And it turns out that they have longer lengths of stay, more difficult. And the bottom article is, I love the title, No Man's Land. Nope, it's our land. And this is by Latronico or Latronico. I've never appropriately pronounced his name. And he started writing on this a while back. And what he's noting in this article is, despite the fact that we've known about this for 20 years, no one has wanted to claim this. And he's saying, wait a minute, just as I've just explained to you, there's as many of these patients or more than there are stroke patients, and we need to be much more aggressive in making this diagnosis and in treating these patients. How common is it? I think, as I showed you in the neurology article, it's about 50% of ICU patients. So that's a lot of people. And remember I said we have 750,000 patients with severe sepsis, but that's only 10% of ICU patients. So now I'm talking close to 8 million ICU patients. And if we look at patients that have been in the ICU for greater than a week on a vent, it's up to 50% of patients. If they had systemic inflammatory response syndrome, which is pretty common, now we can be up to 70% of patients. And look at sepsis patients, 50 to 100%. And the figure that we throw around is pretty much that. The average in between is 70% of patients are going to have critical illness, neuropathy, myopathy. Not even talking about the encephalopathy, which we're going to talk about next. So you should have a high index of suspicion if patients being referred to you that's been on a ventilator greater than a week, been in the ICU greater than a week, that they're going to have this problem. So how do you make the diagnosis? High index of suspicion. So being in the ICU, it's not just that they were at bed rest and didn't get any movement and they were paralyzed, but ICU stay greater than 7 days, being intubated and on a vent, septic, prolonged antibiotics, you can get a steroid myopathy, NMDA is neuromuscular blocking agents, so being paralyzed so you can be on the ventilator or that they're more easy to manage on the ventilator, has its own risk factors, and multiple medications and procedures. So what you want to do if you're a physician, you want to ask your evaluators, your liaisons, who are out there in the acute care hospital, to look and see if these predisposing factors exist and to put it in their evaluation. Say, patient was in the ICU for 14 days, was on a ventilator for 10 days, had septic and septic shock, was on steroids and antibiotic or neuromuscular blocking agents, and right away you ought to have a high index of suspicion that this is what's going on. And then your exam. You don't need an EMG to make this diagnosis. And the case that I will make time and time again is if I have a patient with diabetes, can I make a diagnosis of a diabetic polyneuropathy or a myopathy without an EMG? I can do that all the time. All I need is my physical exam. Now, us neurologists, we have our dorky little bag with all our little toys in it. And so we have tuning forks and reflex hammers, bags of pins, because today, one pin, one patient, because of AIDS and Hep C. So you need to have a bag of pins. But a lot of rehab physicians don't just carry this with them. It's not something that they've gotten the habit of doing, not part of the training. So I think you should ask your hospital and your nursing stations, whether not, let's say you have 5 nursing stations, have them create these what I call neuro boxes or neuro kits that have a tuning fork, and it needs to be a 128, not a 512, which we use for hearing, a reflex hammer and pins, and then they're cheap. Make sure your administrator buys extras because they're going to disappear. And then they're available for you. And when you see the patient, you'll say, hey, can you get me the neuro kit? I need to use it on Mrs. Schmertz. The literature clearly has confirmed that if you think the patient has the diagnosis, you can make it the diagnosis clinically. People have done the EMG and nerve conduction studies to see if their clinical examination is good enough. Here is an article way back over 10 years ago in Chest by Schweikert and Hall, which basically says that patients demonstrating the characteristic exam combined with any evidence of recovery on serial exams, so most of these patients were worse and are now getting better, don't require any further investigation, meaning they don't need an EMG. And an editorial, I don't have that, interesting enough, but there was a Bolton wrote an editorial to this and put it in the same issue of Chest saying that this should be instituted in all intensive care units throughout the United States, or basically anywhere, that it's a clinical examination. It's difficult to do an EMG in an ICU. There's no reason to do it. It can be difficult to do in a rehabilitation hospital. You may not have the machine, the patient may not want to go through it. And if you have the clinical history, which I gave you, and you have the findings on examination, that's all you need to really make the diagnosis. You don't need an EMG and nerve conduction velocity. Here's our fellow Latronico or Latronico. I guess I ought to reach out to him and find out how to properly pronounce his name, who wrote this article in 2005, and now we have the follow-up article this last year. But he looked at what happens to patients with critical illness, neuropathy, myopathy. And he looked at follow-up for up to 8 years. So this was a big study. And 68% regained the ability to breathe spontaneously, which means getting them off the ventilator. But I think we do better than that overall. But if we look at this, many patients with complete functional recovery still had persistent deficits. So we would say, gee, it's significant if they have foot drops, sensory loss, muscle atrophy, weakness. And the 28% had severe disability, quadriparesis, quadriplegia, paraplegia. These are our people. These are the people that need rehabilitation. Remember I said that folks are going to get put on vasopressors to keep the blood pressure up high enough that we definitely need to have that mean arterial pressure of at least 60 to perfuse the brain and the vital organs. Here was an article in Chest to just look at what happens with vasopressor support in septic shock. And here's a picture of one of our patients. He was hospitalized shortly after my wife left rehabilitation, if I get this correctly. He is a young man who developed pneumonia. He developed strep pneumonia and went into septic shock. Within 2-3 days, he also was on a ventilator, dialysis, trying to die, and they were desperately trying to keep his blood pressure up with vasopressor agents. And you can see what happened with the gangrene that he had. He had terrible gangrene of his fingers and feet, and he ended up losing these fingers. Remained little stubs of his thumbs, which was important, and then had bilateral below the knee amputations, and ended up with prostheses. Now, he's an amazing young man who has an amazing wife. So that the good news is he's smart, and he didn't get a bad encephalopathy. He is still a software computer programmer. He had his own business. And his friends turned out to be ingenious, so that they came up with all kinds of devices for him so that he could use software and use his computer. But he uses his computer now with what's left of his thumbs without adaptive equipment and is doing really well. But he has a great wife, and what she said, he was getting frustrated when he first went home and dropping dishes, and she said, I got it, no problem. She bought all plastic dishes, and that way he could help. They have 3 children and young children. They just had a newborn when this happened, with putting the dishes in the dishwasher. Not to be deterred, he started doing all kinds of physical activities. And I think it's now 2 years ago, he and a group of other amputee patients climbed Kilimanjaro in Africa. So that he is really driven, and it shows what can be done despite having significant disability and having this problem. But here's an example of what can happen with vasopressors. We were very fortunate with my wife. I mean, I was worried, but she ended up not losing any digits, toes, fingers. And unfortunately, this young man, you can see the other extreme. So let's talk about cerebral or brain complications. If you go back to thinking about medical school or nursing school, PT school, OT school, whoever's listening to this, there's something called the blood-brain barrier. And the blood-brain barrier is our friend, and it's also our foe.
So it's our friend because it keeps things out of the brain that we don't want to get in there. And let me see if I can get my pointer again down here on this illustration. You can see this is a blood vessel, and this lining is supposed to be the blood-brain barrier. For chemicals or drugs to get across the blood-brain barrier into the brain, they need to be lipophilic, soluble in lipids, and of a certain molecular size. But what happens in sepsis, those cytokines right there in the complement break down the blood-brain barrier, and now they leak across into the brain. And they can get into the brain. Remember what the cytokines do? Here they are, causing terrible inflammation, and so they can cause it. Here's neurons, the cell, the main brain cell, and then there's the supportive cells within the brain, the astrocytes, microglia over here. And so now we get this major inflammatory response. We get neuronal dysfunction and death of neurons. I'm going to go one more slide here. And you get a sepsis-associated encephalopathy. And I'm going to show you why this is a metabolic encephalopathy. So let's go over here, and here's that breakdown in the blood-brain barrier on the left. The circulation now becomes altered, and over here is a section of the brain, so you can see blood vessels can close off, and you get thrombosis and damage in the brain. Right through here is where all the major fibers, this is the internal capsule, not an uncommon location for strokes or hemorrhages in the brain. This is basal ganglia, but you can see these spots, and I'll show you a brain scan of patients with septic shock. So the blood-brain barrier breaks down, circulation now is altered. Remember, we get the cytokines now affecting the neurons, so that brain cells aren't functioning correctly. So we would expect there to be problems with cognition, behavior, just like we would see in any type of brain injury or encephalopathy. And this is altered cerebral metabolism, which means this is a metabolic encephalopathy. Here's our cytokines going in again, microscopic brain injury, breakdown of the blood-brain barrier, and the circle continues to give us a septic or sepsis-associated encephalopathy. Here's a study that looked at cognitive changes in a large group of ICU patients, and this again came out of critical care medicine. And it looked at cognitive dysfunction in ICU patients. And what they found is that for patients that were in the ICU for 5 to 7 days, longer periods of time, not the short stays where you have a procedure and they want to watch you for 2 or 3 days, but the patients that we see very commonly, 70 to 100% of these patients had cognitive impairments at the time of discharge from the ICU. Let me get the pointer out of the way. At 1 year, 2/3 of the patients still had some cognitive or behavioral complaint, and at 2 years, 1/3. And the most common complaints were higher level cognitive problems, and this is the kind of problems we see in traumatic brain injury. Problems with attention, concentration, memory. How about executive functions, planning, initiation, organization? And this will have a significant impact on your ability to function. And as I always say, these are our people. This is what we do in rehabilitation, but it's frequently missed. The ICU doctor, whether they be the primary care doctor or an intensivist, as I said, they're saving lives, so that they're going to get the patient off the ventilator and say, you know, the patient's ready to be discharged from the ICU. And the common description is, well, they've got ICU-itis. We had them in here a long time. They got a lot of drugs. They had sensory deprivation. And don't worry, that's all going to clear. And the family gets reassured that despite the fact that they're having memory problems, that they're agitated, don't worry, over time that's going to clear. But what does this study show us? That if we really look and do cognitive screens, what do we do in rehabilitation? We have speech pathologists and occupational therapists who look at cognitive problems. We're going to find significant problems that need rehabilitation. This is a study out of JAMA back in 2010. So you can see this data, we've been aware of this for a long time. And this looked at the long-term cognitive impairments and functional disabilities. And this is critical because I'm going to want you to get this language into your progress notes and your histories and physicals and your pre-screens as to what are the functional deficits in this large group of patients. So I blew that up for you, and this is looking at activities of daily living after septic shock, and we're going to look at this middle band mainly. And so the upper part is the typical ADLs that we cover in team conference. If I were to go to a group of non-rehabilitation physicians and say, can you give me a list of activities of daily living? I might get no response. I might get, dressing and eating. I don't think they'd get to bathing and hygiene. I don't think they'd get to toileting. So in rehabilitation, a lot of times we first think of grooming, bathing, hygiene, toileting, but we also don't necessarily automatically think of all the higher level ADLs that are impacted. So look at this. This is mild to moderate limitations. Now, and here's over severe limitations. The lighter colored bar was talking to these patients and finding out before they were septic what was their level of functioning, and then afterwards measuring what's the level of functioning. So you can see dressing, bathing, eating, all significantly more impaired, getting into bed. Here's toileting, highest correlation of self-esteem in a human being, continence. Highest correlation of whether you go home after a stroke as opposed to going to a skilled nursing facility is continence. Why do we work so hard on bladder and bowel programs? Because it really affects outcome. It affects on where a patient goes and their self-esteem. But look at these other categories. Meal preparation. What's involved in that? A lot of organizational skills. You have to buy the groceries. You have to be able to read the instructions. You have to organize, do things in the right order. Grocery shopping. Look how impaired this is afterwards. I'll give you a little personal story. So my wife was, we were in acute care for almost a month. We were up in Idaho. We needed to get back to San Antonio. So we got a plane, but we couldn't get the plane for a couple days. My wife insisted on that she had enough of the hospital, and I had a hotel room for a month in Idaho Falls, and she said, well, I can just come there, you can take care of me until we get it. And I'm going, I don't want that responsibility, but she said, you're a doctor, you can do that. And we went, but she couldn't raise her arms up because of her critical illness myopathy. She couldn't raise them up over her shoulders. So it was no problem. I could help wash her hair and help with the shower, but I got time to do her hair. And it was really a mess when I did it. Did it once, and then she was very creative and figured out a way to prop up the hair dryer on a stand and somehow get her hair done. But we flew home, stayed at the rehab hospital at our hospital in San Antonio for about 2 to 3 weeks, and then I got time to go home. And her younger sister was convinced that if I was going to cook, she was going to starve. So she had each of the friends submit 2 recipes, and she created a loose leaf notebook with all these recipes that was supposedly going to be easy for me to cook. And I start to look in this book, and I'm going, these are not easy recipes. One was fish cooked in paper. I think it was snapper and pepiot. And I'm looking, where are the crock pot recipes? So I find one, and then I realize my wife is really a superb cook. And I go, this is going to be great therapy. So we go into the kitchen, and she's standing at the counter, and I said, this is good. We're building endurance standing, and now we need to read the instructions and make a list of what are we going to need at the grocery store, and we're going to need to go to the grocery store and go through and pick out the items. And then in meal preparation, we're going to need to do proper sequencing and organization and planning. And I thought it was fabulous therapy, and I never cooked another meal. So I was lucky because she was doing really well. But these are higher level ADLs that we deal with all the time in rehab that no one thinks about because the patient looks pretty good. They maybe start to walking, even if they're walking with a walker, they're talking, and we're not having any problems with this. But look at, ever had to fill your pill box on a Sunday night? That's when I do mine. Taking medications, managing money, all higher level skills. And a lot of this cognitive type skills gets missed. When my wife was in the intensive care unit in the acute care hospital, they were very aggressive with therapy, started rehab very early. They were a great hospital in Idaho Falls, and they believed in sunshine. So even though the ICU wasn't on the first floor, once she was off the ventilator and capable, we would go outside with a one-on-one nursing and a therapist for her therapy session, and it was great being outside. But young speech pathologist came by, and I don't know that he had a lot of experience with brain injury. And I thought, well, I don't want to make him nervous. So I said, I'll come back after you do your evaluation. And I came back and I said, so what do you think? And he said, well, I think your wife's doing great. I don't think she needs my services. She can speak and she can swallow. And I'm thinking, he totally missed all of the higher level cognitive problems. And she had significant problems, which she recognized. But he failed to ask the most critical question. He didn't ask me the question, what do you think? Do you think that your wife is any different? And as we'll talk about as we go on, it's the single most important question that you can ask. Now, I didn't pursue it any further because I knew we were going to be leaving the hospital, coming to our rehabilitation hospital, and we had a whole group of PTs and of speech pathologists and OTs that could deal with this issue. So here's a study that looked at the long-term cognitive impairment after critical illness, again in the New England Journal. Great source. We frequently forget about it. And look at the number of patients they looked at. Almost 1,200 patients with severe sepsis. And it had significant moderate to severe cognitive impairments. And if you had sepsis, you were 3.3 times more likely to have severe cognitive impairment. And it said an episode of severe sepsis, even when survived, may represent a sentinel event in the lives of patients and their families, resulting in new and often persistent disability, and in some cases resembling dementia. And we miss this all the time. I'm going to go back to that slide for just a minute because I'm not sure if I cover it again a little further down the line. But a lot of times the patient will just say, well, they're debilitated, or they have deconditioning, and we'll order PT and OT, and we won't order a cognitive screen. So every patient that has been in the ICU for greater than 7 days, or the family answers that critical question, do you think they're different, saying, yes, I really do, needs to have a cognitive screen. And what you're going to do is find this significant number of patients with cognitive impairment that needs rehabilitation. This is MRI scans. This was a study that looked at out of the journal Intensive Care Medicine. This was the patient's MRI scan on admission. So they slipped them in the scanner before they probably were intubated with their ventilator. And the ventricles are a little bit probably consistent with age. But now if we look on just 3 weeks later, look at all these white spots. All these we call small bright objects. And throughout the brain, here there's a whole bunch of them. Even more here. These are sections, slices through the brain. Looking, here's the top of the brain going all the way down to the bottom. Here's the eyeballs, nose. And so just within 3 weeks, we're seeing all these microvascular lesions. Remember, I don't know how many slides ago, I showed you the blood vessels closing off from that thrombotic process that takes place with the release of the cytokines. Here's a much more dramatic example. We call these confluent, where they tend to go together, of white matter lesions on both sides of the brain, causing lots of damage. And here's a really nice example looking down of all these white matter lesions on both sides of the brain. This is what's called a sagittal view, looking from the side. Here's the nose, where the letter C is, frontal sinus. This black thing is spinal fluid, lateral ventricle. Look at all the white matter lesions. This is all damaged brain. So we would expect this patient, since it correlates with the severity of the disease, to have identifiable cognitive and behavioral deficits. And look at this, 75% of septic shock patients have an abnormal MRI. It doesn't mean you need to do the MRI. This was a study looking at it,
because we should be able to pick that up in rehabilitation. We should be able to order the speech screen, the cognitive screen, have OT look at them, and find this. This was another series of MRI scans done to show that patients can deteriorate over time. In A, I'm trying to find, there's my cursor. So here's the lateral ventricles. This is spinal fluid. And look how over time they enlarged so that the brain was shrinking. The patient developed atrophy from the brain damage. So as a brain is damaged and the neurons die, the spaces in the brain, the spinal fluid, takes up that space, and we see the ventricles enlarge, going from A to B to C. And down below, it's just looking at it in a sagittal view, looking at it from the side. So rehabilitation after critical illness. So these patients have an acquired injury of the brain, the nerve, and the muscle. This isn't a degenerative disease like Parkinson's or MS. This isn't debilitation and just deconditioning. They have now, through damage to the nerves and the muscles in the brain, developed an acquired injury. So this is no different than if you were to make a diagnosis after someone has a hypoxic injury to their brain to say that they now have an anoxic or hypoxic brain injury and they need rehabilitation. So it's really an opportunity to make a great difference. Rehabilitation makes an enormous difference in these patients who've been in the ICU, and you need to just expunge or get rid of the term debilitation or deconditioning. That is so often, we see the referral coming from the acute care hospital, the patient was in the ICU, and they say, well, the patient was debilitated. And if you think about that previous slide I just showed you, no, they have an acquired brain injury or acquired neuromuscular injury, and their physical function significantly improves with rehabilitation. And it can take a long time to reach maximum recovery. Not going to get there all during their acute rehabilitation stay, and they're going to need long-term follow-up and long-term outpatient therapy. And don't give up on these people. But you need to give up on, unfortunately, so often they go back to their acute care doctor who says, oh, your blood pressure looks good, your statins are doing well, your cholesterol's good, you seem to be talking well, your hemoglobin A1C is good, I'll see you in 3 months. And all of these cognitive and behavioral and activities of daily living issues never get covered. The internet is an incredible resource. This website called ICU Steps is for survivors of intensive care units and is really helpful to families. These patients easily meet medical necessity. They need multiple disciplines. They easily meet the 3-hour rule because they need PT, OT, and almost always speech therapy for cognition. They need an interdisciplinary team. They're complex problems from a medical standpoint, and it's very easy to justify a phase 3 face-to-face visit. So I don't ever have a problem looking at these patients and coming up with a justification for inpatient rehabilitation. I told you how early rehab started with my wife in the ICU. As soon as she was off the ventilator and awake enough, and I wouldn't say that she still had significant cognitive impairments, they were getting up and walking her with a walker in the ICU, and I was incredibly impressed. And then when they said, we're going outside, I was even more impressed. But there's a whole literature on starting rehabilitation in the ICU. Some people have had concerns that if you start rehabilitation too soon after a critical illness or after a brain injury or stroke, that maybe you're going to cause some damage. The truth is, the newer studies show that only maybe within the first 24 hours have some people documented they think that it may have some deleterious effect. And the truth is, we're never starting rehab that soon. They're too busy saving lives with this group of patients. So if you can convince the people at your acute care hospital to start early and to identify these issues and start working on these issues early, the outcomes are going to be better. One of the limiting factors for this typically is resources. So that when you deal with an acute care hospital and say, well, we really think you ought to be doing PT, OT, and speech on these folks, the problem is
that they lack the resources or justify the resources from an economic standpoint, even though the patients do dramatically better. So this is my prettiest example I can find of a glass ceiling. And I always say it's a glass ceiling effect. If you don't do the rehabilitation, the patients don't get better, and it's a self-fulfilling prophecy. So if ICU and sepsis survivors are denied access to inpatient rehabilitation hospitals, they're never going to be able to reach their full recovery potential. I see it all the time where the patient is sent to a skilled nursing facility, never to be referred from there to the inpatient rehab hospital, and somebody says, see, they didn't get better. So I'm glad I didn't refer them because they didn't need rehab. Well, it was a self-fulfilling prophecy because of the glass ceiling effect. So we need to follow these patients if they're not referred to us, if they do go to a skilled nursing facility, if they do go home, a lot of patients with nothing or with home health. We need to follow up. A simple phone call that says, gee, we saw you when you were in the hospital. I know you didn't come for inpatient rehabilitation, but I'm checking in to see how you're doing. Ask that critical question. Is your wife, is your husband, is your son, are they the same person that they were before? Are they having any problems? And you're going to find out many of the times that, oh yeah, they're still having problems, and it's a chance to intervene and really make a difference. Finally, there is a great website called Surviving Sepsis that you can use as a resource for families and lead them to, and these are people that have survived sepsis supporting each other, because we all know there's brain injury support groups, there's MS support groups, stroke support groups, Parkinson's support groups, but there are support groups for people surviving sepsis because you can see that they have this whole group or buckets of symptoms, physical, cognitive, and behavioral, that patients with other acquired brain injuries have. If you have any questions for me, I'm easy to find online. You can go to richard.senelick at encompasshealth.com. I'm really good about answering my emails and answering your questions. And with that, you can also contact us at encompasshealth.com for our other educational offerings. We have other programs on what's the correct dose of rehab, important diagnoses in rehabilitation, brain injury, and stroke. So I want to thank you for joining us for this presentation and hope that you'll join us again for other presentations.